This is the arthroscopy technique for combined anterior cruciate ligament arthroscopic reconstruction and lateral tenodesis using iliotibial band augmented with gracilis tendon. Gracilis harvesting. A 2 cm longitudinal tibial skin incision is centered over the pes anserinus. The sartorius fascia is opened and the gracilis tendon is isolated with a dissector and harvested with an open stripper. The tendon is released from its tibial attachment and sartorius aponeurosis is closed. Iliotibial band harvesting. The skin incision begins 4 cm proximal to the Gerdy tubercle, approximately 8 cm in length. A posterior incision of the iliotibial band is made 1 cm anterior to the posterior intermuscular septum and runs parallel to it. A second incision is made 1 cm anterior and parallel to the previous incision. Proximal extension of incisions is performed to obtain a 3 cm wide graft on its proximal part and a total graft length of 20 cm. The fat part is clear from the graft. Section of the intermuscular septum is performed to facilitate the fascia closure. The insertion in Gerdy tubercle is kept attached. Femoral isometric point repair. It is located 5 mm behind and 5 mm under the femoral insertion of the lateral collateral ligament, just under genicular vessels. This point is marked by electrocautery. Graft preparation. The level of the femoral entry point is marked on the iliotibial band. This mark corresponds to the beginning of the reinforced part of the graft. Tubulization is then performed. The gracilis tendon is placed inside the iliotibial band. A first stopping suture with number 2 vicryl is proceeded at the level of the landmark. Then 2 other sutures are proceeded with the grafts stretched. The grafts are tubulized with number 2 vicryl suture passed through the free margin as torsion suture. The graft is then measured to define the diameter at the femur and the tibia. Femoral pining. The femoral tunnel is created with the outside-in technique. The tip of the guide is inserted into the medial portal. The intra-articular guide pin penetrates 5 mm distal to the notch outlet between 10 and 11 o'clock on the right knee and between 1 and 2 o'clock on the left knee. Tibial tunnel. The tibial tunnel is created using a tibial drill guide set to 40 degrees. The angle of the tip of the drill guide is inserted through the anteromedial portal and positioned centering the ischial remnant. Femoral tunnel. The femoral isometric repair is located 5 mm behind and 5 mm under the femoral insertion of the lateral collateral ligament. The guide is passed through the extra-articular femoral landmark previously established. The drill is then pushed through the guide and a 6 mm reamer is used to prepare the tunnel. Then, a reamer corresponding to the measured graft diameter is used. Debridement is performed. Graft passage and fixation. The traction thread is passed through the femoral tunnel in a outside-in direction and then recovered with an arthroscopic grasper through the medial portal, and then pulled out of the tibial tunnel. The graft is tensioned by cycling the knee. The knee is placed in full extension with the foot in neutral rotation. The guide pin is inserted in the tibial tunnel. The graft is then fixed at the tibia with a bioabsorbable interference resorbable screw. No femoral fixation is required. However, an additional screw can be used on the femoral tunnel. This is the arthroscopic control. Wound closure. The iliotibial band is closed step by step with number 2 vicryl separated sutures. Subcutaneous and skin layers are closed with absorbable sutures.